a little bit about the lab that I work in. So I'm part of the Electronic Health Information Lab, which is part of CHIO and University of Ottawa. And the eHIL lab does a lot of interesting things, none of which really relates to psychology or behavioral economics. So they actually do a lot of research on software that's used to protect electronic records. So for example, in a hospital, or if you're a pharmacy company or a pharmaceutical company and you have records of different tests. So that's the type of thing that they work on. A couple years ago, they developed a really sophisticated software that was going to be used to help match up different databases of records. And so anyway, I can't tell you any of the specifics about it because I don't know anything about it. Basically, they went out to different universities, different hospitals, different companies and tried to sell it. And the important part of the software is that it did it in a very secure way using de-identification of data, which again, I know nothing about and I can't tell you about. But it's like the crux of internet security. And so they went out and tried to sell it. And obviously, their pitch went something like this. We have this amazing software. We want you to use it to protect health data, which is legally required of you by the government. Please buy our software. And there's no other really good competition, so you should just buy our software. Privacy officers were really reticent to buy the software. They didn't seem to be convinced, or they thought maybe something else was going on. For whatever reason, they were having a really hard time selling it. And then I came into the picture because I met Khaled briefly, and he was telling me about this problem. And I said, that's kind of interesting. Do you think there's maybe an ironic problem where you tell someone how safe and secure they are, and instead of making them feel safe and secure, they actually feel a little bit less secure? And he was like, I never thought about that. So he found some money to get me a postdoc, and that's what I've been doing for the last year and a half or so. And so I'm going to be talking to you about some research that's come out of this casual conversation, and hopefully I'll convince you too. And before I start, if you interrupt me at any time, I'll be very happy to answer your questions. I don't know exactly what people's backgrounds are, so I'll try to go through terminology as much as I can, but there is a lot of jargon. So again, stop me if you're confused at any point, because probably someone else is. Okay, so today I'm going to be talking to you about the perilous promise of privacy. I will be. I will not be. Oh, it's waiting. No, no. Yeah, it's okay. It's just being slow. Okay. They're relying on you giving them full information to make a diagnosis to help care for you better. The problem is that patients are not always forthcoming, and that's not really that surprising. They often underreport in a variety of different circumstances. For example, influenza, sexually transmitted infections, even simple things like cigarette smoking. So if you are a cigarette smoker and you're trying to quit smoking and you go to your doctor's office and they say, are you still smoking? You might say, no, I'm not smoking because I'm no longer identifying as a smoker, but you're occasionally having a cigarette, but like you're not telling him about it because it's not a big deal to you, but still technically you're smoking. That does influence a lot of other health factors. And so the argument here is that we should be able to convey to patients that they're in a safe and secure setting, and that should allow them to be more comfortable telling us about the occasional cigarette that they're having. And the idea here is that we can do two different things to convey safety. So the first is we can tell people that anything that we're collecting from them is anonymous. And so when I say anonymous, I mean that any personal information associated with their disclosure is taken out. So if I tell you you're anonymous, I mean that your name, your postal code is not associated with what you tell me. The other way we can convey safety is by telling people that the information they're disclosing is confidential. So, for example, a doctor might say, if you tell me you've had a couple cigarettes, that's okay. It's between us. It's a confidential relationship. technically. So, for example, electronic information can be confidential if it's secured in a building, or if data is encrypted, so it can't be accessed by everybody. So those are the two keywords I'm going to be using today, and anonymity and confidentiality. They kind of feel interchangeable. For the purposes of this talk, they mostly are, but it's important to know what they mean. Also, can everyone in the back hear me? Yeah, okay. I'm a little person, so it's hard to project sometimes. Okay, so what I've alluded to is that these security assurances might not actually be conveying safety to people. So telling people that everything they disclose is anonymous and confidential might not actually make them feel as though they are anonymous and confidential. And so I'm going to run through an example with newborn screening. I know there are some newborn screening experts in the room and some people who don't know about it. So I'll try to be as clear as possible. But this is kind of an interesting example of how this problem exists in the real world. So newborn screening, for those of you who don't know, when you have a baby in Canada, they take a small sample of blood from the baby. They test the baby for a variety of different horrific illnesses that could be, if treated early, can save the baby. So there's generally not much cost associated with it, a lot of benefits for the baby. The way that newborn screening is consented for is a little unusual. So it's not like participating in any other medical study or any other medical procedure. You don't get a full consent form and read through it and sign it. Generally, it's done with presumed consent, which means that they're going to take the blood sample unless you clearly state that you don't want them to. And even in that case, sometimes it happens. So the consent is usually, if it is obtained in a more traditional way, it's obtained right after birth. Most people who have just had a baby are not really thinking clearly about consent. They just want to hang out with their baby. So there are some issues that have to do with the sort of primary consent for the procedure. That's problematic for some other reasons that we could talk about later. But for our purposes, and this example's purposes, what's interesting is that the samples taken from babies, so these little spots of blood, are actually saved in a database, and they're used for other research. And usually the research is great things like finding new ways to prevent disease or finding new indicators of other things that make babies sick. But if you haven't consented for the original procedure, then how can you have consented for the secondary use? So that's kind of the big problem with newborn screening. And there have actually been several legal cases, big legal cases, that have looked at just this question. So basically, parents find out that their child's blood has been stored somewhere. They don't remember consenting, probably because they haven't. And they get pretty upset about it. They want to stop their child's sample from being used. They get news coverage. Other parents realize they haven't consented. And then you have a case like what happened in Texas. So in Texas, this is basically exactly what went down. Parents got aggravated, and the state was ordered to destroy over 4 million blood samples. So that's, an entire research base right there, just because of these consent issues. The same thing happened in Minnesota. This one actually recently, they were ordered to destroy, I think, around 2 million samples. So the same thing. There's an ongoing case in Vancouver, which I don't know about the outcome of, but you can see this is sort of happening not just in America, where they are a little more liberal with their lawsuits, but also in Canada, where things are a little more tame, I guess. And so what's kind of come out of these studies is, again, a prescription by health authorities to give people more assurances. So to tell people, when I'm asking for consent for this blood sample, I'm going to store it in a safe place. Your sample is anonymous, so I don't know which one is your child or which one is your neighbor's child. So just really driving home this message of reminding people that everything is safe and secure. And indeed, this is not new just to newborn screening, but it's part of most regulatory bodies these days. So for example, HIPAA, which is the American, basically anytime you're using patients, you have to go through a HIPAA consent form. There are actually 7 paragraphs of the consent form dedicated to privacy, security, confidentiality, anonymity. That's a lot to read. especially if you don't read consent forms for a living. CIHR, which is a Canadian funding agency, which I'm sure you guys already know. They require you to give a full description of all the security practices that you're going to use to protect the data. Privacy by Design, which is an Ontario agency run by the Privacy Commissioner of Canada, requires that as the sensitivity of the data you're collecting increases, so should the amount of information you give about confidentiality and anonymity. So basically, the more sensitive it is, the more you need to tell people you're protecting them. And more generally, ethics boards across universities, any research institutions, require you to include at least some statement of confidentiality or anonymity. So anytime you're going to do research, you have to now have these statements in place. And again, here the idea is that these institutions want to protect you as a participant or a patient. But as I've alluded to several times now, these assurances might have ironic consequences. So they might not actually be telling people, yes, you're safe and secure. They might actually make them think maybe that something's compromising. And so there are sort of two ways that this can happen. I'm going to talk about two different ironic consequences, one of anonymity, one of confidentiality. Bart is wearing a mask. That's how I'm getting you to remember what anonymity is. You can't see his face. It's Friday, so I thought you guys should have some fun while you're in this. That's okay. So again, when you tell someone that the information they're giving you is anonymous, it can actually decrease the accuracy and consistency of the information that they give you, and it can reduce the accountability of their responses. And so you can think about this in your own life. So if someone tells you, don't worry, the information you're giving me is completely anonymous. Say they're asking about your smoking behavior and you've recently quit, but you had a cigarette the other day and you're not telling anyone about it. If someone tells you you're anonymous, that also means that there's no way that they can check whether or not you were lying. And so this is potentially one avenue that people use to sort of justify lying. So when you tell someone that the information that you're collecting is anonymous, you're also telling them that there's no way that you can check that they were lying. The ironic effects of confidentiality are very similar. When you tell someone that the information that you're giving them is that the information they're giving you is confidential, they actually are more likely to withhold information, so they're more likely to select non-response options or just not to answer your questionnaire. And they're also more likely to report increased skepticism. And this is important. So I like to use this example of like talking with your best friend, just don't worry, I'm not going to tell anyone. That's like saying this is confidential, but you know she's probably going to like go gossip later on. So we have this sort of like social feeling that confidentiality can be breached. And in fact, confidentiality might actually remind us that the information we're giving is highly valuable. And so instead of acting as like a description of what's happening, people see it as a warning. Warning, this information is important, you should withhold it, as opposed to saying, this is a safe environment for you to disclose this information. So those are kind of the two ironic effects that we're going to be talking about today. Is everything make sense? Okay, great. So I'm going to talk to you today about two different studies that we've run. I was saying earlier, the first one is kind of like a setup for the second, and the second one is like really where the action is, so bear with me through the first. Basically, what we're going to be looking at is whether or not anonymity and confidentiality influence disclosure rates, and I'll talk about how we measure that a little bit later. But our main hypothesis, if I haven't made it clear yet, is that actually discourage disclosure. So telling someone that they're safe and secure actually makes them feel less safe and secure. So the methodology of our studies is pretty straightforward. I'll just go through it now. The two studies are almost the same in terms of how we run them. So basically, we recruit participants online from a service called Crowdflower. If you have questions about it, I can tell you later, but basically people do it for a really small sum of money. They come in, they do a study really quickly, and then they're out. So we recruit participants from there. We have them read a consent form, and in this consent form is where we manipulate our conditions. So we either include or take out confidentiality information. And then once they've consented to participate, we ask them to fill out a short health behaviors questionnaire. So we ask them to disclose different types of health behavior. So we asked them if they've ever had a heart attack, if they've ever smoked, how often they drink, these types of things. And so we have 17 different ones that we asked them. I can tell you about it later if you care. I'll get to more about how we ask them to respond shortly. But basically, they respond to these questions, and then once they've finished, we thank them, and we debrief them, and we tell them about the hypotheses of the study. So the first study is really a 2-by-2 design. So we varied whether or not we included anonymity assurances, confidentiality assurances, and then we also varied whether or not we told participants that they were completing a study for our lab or for a hypothetical fictional marketing company that we made up. I won't talk about those results today. They're sort of part of a different project, but if you do have questions, again, everything is on the table.
Just one quick question. How
Yeah.
does your REB allow you not to assure confidentiality?
We put in the debrief that everything was anonymous and confidential. Yeah. They weren't really, they were sort of like, yeah, that seems fine, which was kind of surprising. But I think because we're specifically studying the confidentiality, they sort of have to. Yeah. It's important to play the political game with them. Right, so we're varying whether anonymity and confidentiality are included in our consent form. And so you're probably thinking, how did you do this? This is taken straight from the CHIO required consent form. So they have a large section on confidentiality and privacy. And what we did is, I don't know if you can read it, but underlined in red is everything to do with anonymity, and underlined in blue is everything to do with confidentiality. And we just varied which of those pieces of information was included. And again, they saw the full slew at the very end, regardless of what condition they were in. So some people saw this whole thing, some people saw all the underlined stuff removed, some people saw a combination thereof. And I said I would talk to you more about how we measure disclosure. So this is it. We have two different ways that we're going to measure disclosure. The first is what I call a social proximity. So basically, we've given participants this type of question of, have you or anyone in your family ever been diagnosed with any type of cancer? And there are a couple different ways you can respond to this option. So you can say no, yes, someone in my distant family, yes, someone in my immediate family, yes, I have been diagnosed, or prefer not to say. And so we rationalize that a socially proximal response, saying I have been diagnosed, is more of a disclosure than saying someone in my distant family has been diagnosed. So we're using this sort of as a scale of the amount of disclosure, because technically you're part of your distant family. So if you didn't really want to admit, you could say, someone in my distant family has been diagnosed with cancer or smoke, without specifically identifying yourself. And again, because we're looking at relative disclosure rates, it's not such a big deal that one group might have an actual higher incidence. So is that sort of clear? Because that's going to be the big thing throughout. Okay. The second way we measure disclosure is by looking at this prefer not to say option. Basically, it's a non-response option. The way our survey is set up, you can't continue on to the next page until you've filled out every question. So if they don't want to respond, they have to select this option. We'll be looking at a rough count of how many people select it. So when I go through the results, first I'll talk about the social proximity, and then I'll talk about the non-response options. So in the first study, we see a three-way interaction. Again, I won't talk about the sector stuff. But basically, participants, so you can see in this graph, along the y-axis, we have this standardized health index score. And that's, we take all the 17 measures, all the 17 questions we ask participants to disclose. We standardize responses, and then we aggregated them into this one index score. So that's what you're seeing here. So basically, more positive scores mean that they've disclosed more information. More negative scores means they've disclosed less information. And what you can see here is that the yellow bar represents, the yellow bar represents when there's no confidentiality assurance, and the orange bar represents when there is a confidentiality assurance. And what you can see is that participants are much more likely to disclose information when they don't see an assurance. So this is kind of our first piece of evidence that maybe our hypothesis is correct. that participants are actually less likely to admit things when we tell them they're safe and secure.
How many respondents were there?
This one was a big study. It was about 500 people. So this was about 250. Yeah. Again, we also looked at prefer not to say options. So this is the non-response option. And this is just a refresher of what the question looks like. So what we can see here is that there was a marginal interaction of confidentiality and anonymity. Basically, if anonymity was assured, a confidentiality assurance increased the number of non-response rates. So people are less likely to give information when you give them anonymity and confidentiality assurances. So to summarize study 1, anonymity and confidentiality, when they're explicitly assured, make people actually less likely to disclose information. So they're less willing to share information with us. And the marginal effect in prefer not to say options suggests that people might actually be more likely to opt out of studies when we give them these assurances. So in this cartoon, Bart is sitting with the counselor, and the counselor saying, "Don't worry, everything you're telling me is confidential." Bart seems to be kind of looking over to see, oh, this door is open, maybe the twins can hear. So he's kind of like looking for potential sources of breach. It's the closest I could get in The Simpsons, so you have to bear with me. But it does seem to suggest that there is a sort of ironic consequence happening. So the link between study 1 and study 2 is maybe not so intuitive. But what we've been saying so far in study 1 is that paying attention to these anonymity and confidentiality assurances is probably a critical component to the effect, right? So if Homer is thinking about confidentiality, he might be less likely to disclose information to us, but if he's not paying attention, he's thinking about donuts, then he might just willy-nilly disclose everything. So attention to the actual assurances within the consent form is probably an important part of this effect. And so study 2 was designed to look at this a little more clearly. So the idea here is that if participants report more attention towards anonymity and confidentiality statements within the consent form, they should be less likely to disclose. And so the second hypothesis we have is that subjective attention should act as a moderator of the effects of study 1. So again, if it's not super clear, when Bart is to what the counselor is saying, he's probably more likely to disclose, but if he's spending a lot of time thinking about the confidentiality, he's less likely to disclose. Those are our hypotheses. So the methodology of study 2 is almost identical. There are 2 really small changes. The first is that in study 1, there was a lot of confusion, especially by participants, over what anonymity and confidentiality mean. So we just combined them into one assurance variable. So participants either saw both confidentiality and anonymity within the consent form, or they saw neither. And it just makes it a little easier to read what's going on. The second is that once participants had completed the entire questionnaire of health behaviors, we asked them to report their subjective attention to the consent form, and I'll get into that now. I'll get into that shortly. So in this study, we have a different design, 2x4. So there are 2 different assurance conditions. So as I said, people are either assured of confidentiality and anonymity, or they were not assured at all. And then we have participants self-select themselves into one of 4 groups with regard to how much attention they reported paying to the consent form. So we asked them this really simple question after they'd completed everything. Do you remember reading a consent form and agreeing to participate by clicking I consent? And we gave them 4 response options. So the first is, I remember consenting vividly. I remember glossing through the form and consenting. I didn't read the form, I just clicked consent, or I don't remember. And then we also gave them a prefer not to say option, but no one actually selected that, so it won't be in the analysis. And I should actually say now that the I do not remember option was only 7 people. We didn't remove them from analysis, and it doesn't change any of the effects, but for the purpose of showing you a nicer looking graph, I've taken them out. So we're looking again at this social proximity scale. So again, we have disclosure on the y-axis, so more disclosure is more positive, less disclosure is more negative. And on the x-axis, we basically have attention. So high attention is people who reported vividly remembering. Low attention is people who reported not even reading the consent form, just clicking consent. And what we can see very clearly is that as people report less attention, they report more disclosure. So people who are really spending time reading the consent form are actually less likely to give us health information. And this relationship is driven by people who read consent forms that included confidentiality and anonymity assurances. So people who are reading assurances clearly are not disclosing information to you, and people who don't even see the assurance are disclosing everything. So this is like a pretty nice demonstration that attention is important when thinking about disclosure. Oh, check the airflow. Okay, it's just up here, it's not here. Okay, great. All right. So that's basically the same thing, but we have the main effect, and we also have the correlation. When we looked at, oh, really? It's the same thing when you look at the prefer not to say or non-response options. So there's a main effect of assurance on disclosure. Should we wait this out? No, it's just a picture. So basically, people who saw an assurance were more likely to select non-response options. Again, people who are seeing confidentiality and anonymity are less likely to participate in our study. Okay, so to summarize study 2, again, we showed that disclosure was negatively correlated with disclosures. Sorry. Disclosure was negatively correlated with assurances. So when we gave people more assurances, they were less likely to disclose information to us. But we also saw that this effect was moderated by attention. So we saw this ironic problem for people who had paid attention to our consent forms, which is something that you want, but not for people who just sort of went through and clicked and weren't really paying attention. And this is really, really important because it suggests that it's the attention to the assurance, not to the consent form in general, which is causing the problem. So it's not the consent process, it's the important parts in the consent form relating to confidentiality and anonymity, which, again, are things that are legally required by you to include in your consent form. And these are the things which are making people feel skeptical, making them concerned, and reducing their disclosure. Yeah?
If I'm correct, but could it be that the people that read actually carefully the consent form are the ones that are less willing to disclose by nature? Right?
It could be.
That it's written in there, it's the fact that...
Yeah, it's a personal trait rather than... it could be. I think it's possible that there are a group of people who would do an online study and kind of disclose information. There are a group of them that may be more cautious. We've run in this population like hundreds of people, and there's not really any. We've looked at different ways of measuring how attentive they are to the study, so how long they spend actually completing the study, how long they spend reading other parts of the study, and none of those seem to correlate with their behavior. It's just this measure of whether or not they remember the consent form, whether or not they remember that assurance being in there. So there probably is a part of it that has to do with personality traits, but I don't think it's the full picture, and I think that's the problem.
Do you have information on how much time they spend on clicking your survey? So can you validate their own assessment of whether they remember this process in terms of time?
From what I remember, we did find that for the 3 groups I showed you, people who reported having a stronger memory also spent longer reading the consent form. The group at the end that I didn't show you, the 7 people who don't remember anything, they're kind of all over the place. So, I think they're all over the place in general. So I haven't shown them to you in analysis, but we don't, and we have kind of a rough measure of how long they spent on the study that doesn't correlate with any of those other measures. So, to answer your question?
Yeah, no, thank you.
Okay.
You don't have demographics information on people, like education level, definitely.
Yeah. Not for this study. We used to have a really broad demographics that we ran at the beginning of each of our studies. It was the same every time. It's a really broad mix of people. So it's not just like 18-year-olds who are sitting at home. You do get people who have, postgraduate, post-secondary education. You do get people who are in a higher income bracket. For the most part, usually the average age is like in the mid to late 30s, and the average income is like nowhere. It's like middle ground. It's not really extremely poor. It's not really wealthy either. Yeah. Yeah, that's a good idea actually. I don't have that data here, and I don't have a pen, but that would be a really cool idea. Yeah, be good to look at. Okay, so I don't know if I'm going to bother going through the rest of my slides. But in general, the work that I presented today suggests that these ironic effects of anonymity and confidentiality seem to be triggering what the assurance means to the participant. So instead of seeing these messages, as a message of decreased risk or of safety practices, they're actually reinterpreting it as a warning, which is a signal of increased risk. So participants are going based on their feeling of risk rather than the actual understanding of what the message is. And so researchers, policymakers, people like us who have the good intention to take care when they're collecting information from patients and participants might actually be compromising the quality and quantity of the data that they're collecting by using these methods. And what we have demonstrated is that more comprehensive consent forms that include lengthy privacy notices, confidentiality statements, and so on, might actually only be helping at the cost of reduced attention. So it seems probably getting a trade-off between disclosure rates and understanding of the consent form, where you either get high disclosure and low understanding or low disclosure and high understanding. So what we're working on now, you can't see, is we're looking at new ways of designing consent forms, and we're drawing a lot on the business literature. So we're looking at what companies are using for their privacy policies and trying to implicate some of those details in the health setting. So the first is shortened consent forms that have hyperlinks. So just seeing a link to a privacy policy might be a way to convey that their information is protected without making it so explicit. The second is by using brief but expandable statements. So Facebook uses this actually. So they have, a one-line information we received and how it's used. If you want to know more, you click on it. It opens up a whole thing. But this is kind of a nice way to show people we're thinking about this without explicitly telling them so much about your confidentiality practices. And I'm obviously happy to talk more about different opportunities, different ideas. Thank you very much for your attention on a Friday afternoon. But I will take questions. I will take questions. Okay. Yeah.
I like Patricia's question, and that raised, obviously the question about whether there are underlying personality traits in states and so on. So
yeah.
A future avenue of research would be to sort of measure those things and see if they're correlated with responses.
Yeah.
The question, though, is about the magnitude and the durability of the impact.
Right.
So is it, do you have a sense of whether this is a really large psychological effect? I mean, it's present, clearly, from your study, but the question is, how big is it? And then the secondary question is, how long does it last? I mean, so if you're getting people to sign consent, that's one thing, but if they forget about it the next day and they participate in the study and they're giving you the same information, then maybe it's not so important. Yeah.
So we're looking at, one of the ways that we're looking at playing around with this effect is separating consent time and study participation temporally. So having people sign a consent form, watch a video, and then participate in the study. There's some work by Idris Adjadid, who's at Indiana University now, and he's shown that you can temporally separate something similar and show the sort of the ironic effect is attenuated. So we're hoping to do something like that because I do think it's important, right? In a clinical setting, you consent for something and the procedure doesn't happen immediately. It happens, later on, and especially when you're thinking about secondary use of any data collected, that's far down the road. But again, if people are disclosing to you some information right away, it is important to think about how they're going to respond in that time frame. Yeah. Sorry, any kind of first question?
I mean, obviously, your results apply to what people say right away, but many of these research studies that go on for a long period of time, and you're gathering information. So I guess my only point is if there is a real effect that it attenuates over time, it will bear on kind of the consent process, but it may not bear so much on the validity of the data that's gathered later on in the study.
Yeah, that's true.
That was my only point.
Yeah, I think that's true. Oh, and your first question was about the robustness of the effect?
Well, the magnitude of the effect. Like, is it a really big effect, or is it, like, not so big?
It ranges from study to study. I would say it's small, but we've replicated like 7 or 8 times, so I think it's there, it's there. Yeah.
When you collect these data and source of stability, a lot of public discussion now in the wake up, with related about privacy, confidentiality. So, is some of this reaction to public opinion about confidentiality?
I don't know. I would think probably not. We've been running these studies for the better part of 18 months, and we haven't seen a trend in increasing or decreasing. Again, the effect is small, but I wouldn't be able to speak to that. It'd be interesting if it was. I think people should be more aware, but my experience tells me they're probably not. But yeah, that's a really interesting idea. Yeah.
Have you considered maybe posing the same individual, same subject, different consent form?
We have thought about having people come back and do a second survey. We haven't run it. I would be really interested to see how that plays out, because that would kind of speak to this sort of temporal angle as well. Yeah, that would be a really interesting idea. Yeah.
Can you talk about your experience using Crowdflower? Like, is that a really cool, useful?
Yeah, super useful. I am a huge Crowdflower pump person. So when I was in grad school, I used Amazon Mechanical Turk near the very end of my dissertation, and it was like amazing. So sorry, what do you want me to speak to?
Well, just
I'll just go
what
on.
it is, how it works, and
right.
what kind of studies
Yeah.
it might be useful for.
Okay, so Crowdflower is an online crowdsourcing tool, and basically what it is there's a network of people who complete studies or complete, I think they call them like hits, or they call them something different than a research study, but you can basically put up your survey, and you can pay them based on however much you think that they deserve to have. It's for really, really small amounts of money. And for that reason, we restrict our samples to Canada and the U.S. because, 25 cents in Canada is nothing, but in other economies it is. So we want to make sure people are doing this more for the fun of it and not for the cash value. And there are actually some people who, try to bug the system, and they run from different IP addresses and stuff. We take all those people out, but it's generally a pretty small percentage. So you can really make it as specific as you want to your demographics. In terms of who is participating. And you can make the survey of any length. We have ours set up. It's just a link from the Crowdflower page to our personal site, so you can run everything yourself, collect all the data, don't have to go through them, although I think they do actually offer those services. A lot of stuff that's on there is corporate, so different companies looking to see which web page people like best, or what types of products people are looking for. So there's a pretty wide range of things that are up there, and I think that actually is a benefit, because then nobody's thinking like, well, what's the purpose of this? It's just like this other thing I did where they were looking at X, Y, and Z. So they're a little bit less looking for. There, I think, are less demand effects on Crowdflower than maybe in a traditional setting. Part of the reason we chose crowdflower is because we only have student samples at the university. And I'm not sure how many undergrads you know, but none of them have health problems. They just, like, if you give them the type of questionnaire we gave, they, don't really have anything. So we wanted a sample that, had family members who had had heart attacks and had personally had experience in the health setting. So that was the primary reason we chose them, but there are a lot of other interesting dynamics to that group. Yeah.
Okay, so I had a question. So I'm wondering if that kind of design would bias already your study and one, like towards recruiting participants that are more likely to share information. So
Yeah.
getting away.
Yeah, so people who use crowdflower are more computer literate than lay people you would get, recruiting from a hospital, for example. We're looking to do a real patient study, mostly to examine whether or not this happens with a sample that's not as literate. With that said, populations who are more computer literate also tend to know more about privacy. They tend to be a bit more aware, like they have different email addresses they use for crowdflower versus personal. So they're more aware of the types of things that can happen online. So I would say that it could bias our data in the opposite way that we've seen. So it could make them actually less likely to disclose in general. But you're right, it could make them more likely to disclose.
Do you know if you can get general population samples from crowdflower? Like, could you get a representative sample of the entire Canadian population, or could you get like a heart failure population? Like, is it possible to select?
They're a bit strict about how they let you. You can only do it by country, and I don't know specifically about Canada. We're running our first all-Canadian study in the next month or so I can let you know. I think there's just fewer Canadians, but I still think you could get a good sample. With regards to specific health conditions, I think it would be harder. I know that what you can do is set up, you can have like entry questions, and if they get the entry question correct, they can go on. So your entry question could be like, have you ever had heart failure? And then they could go on. But I don't think there's a specific way you can discount those people from participating entirely. Yeah.
Does it provide information on unique users and how many surveys they responded to?
You can get that, yeah.
Okay.
Yeah. They have like gold status.
I was asking. I mean, if you have someone who's on there all the time and is
Yeah.
going to do, 50 surveys, they might be more likely and more comfortable.
Yeah, that's true.
Yeah.
That's true.
Or they may just fill in like anything.
Exactly.
Yeah.
Yeah.
Doesn't need to be red, like just like whatever.
Yeah.
So click through, get the 25 cents.
Yeah.
Exactly. Goes like randomly.
Yeah. What is nice is you can look at how long people have spent completing the survey. And so generally we take out people who spent less than a minute because they tend to, there's like a group of people who take like 45 seconds, and then there's like from 3 minutes on is like about how long they spend on their study. So we usually take those people out. You can set up your settings in a way to really minimize it, which is, there's
They will just log off. They can't get